Hi everyone, welcome back to the afternoon session. We're going to get right to the first speaker, Pilar Osorio, who is a professor of law and bioethics at the University of Wisconsin. So without further ado.
Thank you. And I really want to thank the organizers for inviting me. This is only the second time I've come to this meeting, and it's lovely to look out and see faces that I saw last year and some new faces. So I'm a bioethicist, but I am not going to spend this time talking about every ethical issue relating to machine learning and healthcare. We can't do that. But if you have questions, I'm here the rest of the day and tomorrow, and I'll be on the panel tomorrow. So if you have questions about other ethical issues, please ask me. For right now, I'm going to focus on justice in machine learning for healthcare. And so what I'm going to do is first talk a little bit about the concept of justice, and then talk about how machine learning might either exacerbate or ameliorate injustices that currently exist in the healthcare system. And then finally talk about what we can do to tilt the balance towards the better side, right? All right, so first of all, justice is something that people have been writing about for thousands of years. There are many thousands of really smart and thoughtful books on the topic. But as an applied ethicist, one of the things we try to do is work in an area of what we might call overlapping consensus. So we tend to work with concepts and principles where many different theories could all agree that something is less just or more just, right? So we don't have to get into the deep details, at least right now, of any particular justice theory. There are many things that can happen in healthcare and in which machine learning might play a role, where almost any theory might agree that certain things are not very just. For instance, if a group of people is systematically denied adequate treatment because of their race or gender or some other feature, almost all theories of justice are going to consider that unjust or less just, although they might have different ideas about why that would be unjust, right? So we're, even without having an elaborate theory of justice, there's a lot we can say about how machine learning might play a role in creating more justice or less justice in the healthcare system. So health plays a pretty significant role in many justice theories. It's considered a special kind of a good, or something that we value in a special way, because health is instrumental in us achieving so many aspects of our life plans and our important life goals, right? So it's a very significant kind of good. It's also something that we value in and of itself, right? We value it instrumentally because it allows us, for instance, to take advantage of important opportunities. That's an instrumental way of valuing health. But we also value it in and of itself, right? It feels good to feel good. So it's both an instrumental kind of a good and an intrinsic good. And sometimes it's a positional good. And by that, what I mean is that it might matter in terms of my access to things like opportunities or my ability to exercise my rights if somebody else has a lot more health than I do, right? So it can matter in relation to how much other people have. And that's both individually and in groups. So health is a very complicated kind of good. So when we talk about justice, we're talking about sort of distribution of things that make life go well or poorly. That's distributive justice. Who gets what? We're also talking about substantive justice. What should people get and how should they be treated? That second part, how should people be treated by their institutions, is an important aspect of justice that maybe often gets sort of underappreciated and is important with respect to healthcare, right? Because the healthcare system is a significant portion of our entire economy. Almost everybody interacts with it at various points along their life. Even if your medical problem cannot be cured, it matters if some groups of people systematically get more attention and some groups systematically get less, right? That is an aspect of justice, right? Is how much respect you are being accorded, how the system is responding to your needs, even if the healthcare system can't always cure your disease or treat your disease or even identify your disease or condition. So we have distributive justice, who gets what in terms of certain kinds of goods that are important, like who gets how much of the healthcare dollars that are spent. We have substantive justice. We also have procedural justice, right? That's about how do we decide who gets what and how people are treated. So again, justice is a very complex set of concepts. There's more than one kind of justice, and I think that machine learning can play a role in all of these aspects of justice relating to the healthcare system. All right, so we know when we go outside of the healthcare system that there are now numerous examples, I hope you are familiar with some of them at least, of ways in which machine learning can potentially exacerbate injustice because real-world data on which we train our algorithms is structured by all kinds of pernicious biases, or it can be. And there are lots and lots of examples of this. I am not going to go into them here, but I do recommend. There are some really excellent authors who have done deep dives into the ways in which training algorithms on real-world data sometimes ends up creating basically a racist or sexist application in the world. And there are people who are devoting their careers to figuring out how to identify when that's happening and how to help algorithms become less biased, not just in the statistical sense, but in the pernicious kind of sense. So the question for me is, we see this in all kinds of other domains. In healthcare, people have not yet really done deep dives into the ways in which algorithms might be either perpetuating various kinds of injustice and pernicious bias or ameliorating it. But I think we can predict, and we can try to get ahead of this set of issues. So before I go further, I just want to say that there are some assumptions that I'm going to make here that we don't have time to discuss, right? So one of the assumptions I'm going to make, and you might not think this is a questionable assumption, but many people who work in the healthcare system might think this is a questionable assumption, is that the operation of the healthcare system actually promotes health, or it can, right? So we wouldn't really have justice problems in so far as, do people have access to healthcare? How does the healthcare system treat them? We would have far fewer justice problems if the operation of the healthcare system didn't or wasn't able to actually improve people's health. But I'm going to assume that it can. And so it does matter from a justice perspective. And as I said earlier, I think because healthcare systems are such important institutions in our society that occupy so much of this society's economy, even when the healthcare system can't take care of your problem, it still matters how you are treated by that system and whether that system pays attention to your problem appropriately. And then I do assume that the operation of machine learning and integration of it into healthcare systems can affect the justice of the system. So with that, I'm going to say we've talked just a teeny tiny bit about justice. I want to spend a few minutes talking about ways in which existing kinds of biases structure healthcare data, because I think what matters in machine learning and justice is that the ways in which we get pernicious bias into a machine learning product, right, something that would be implemented in the healthcare system, is by training it on data sets that have these unsuspected biases in them, right? And so how does that happen? It happens because of biases in the healthcare system. And so I just want to talk a little bit about how they get there. And I know this morning you heard a little bit about sort of ways in which maybe women's pain or life experience are not well valued or captured in the healthcare system. So that would be perhaps one kind of example here. I'm going to give you a couple of others, and then I'm just going to say a few words about how actually the processes of training algorithms might make the problems even worse if we're not aware. So obviously there are lots of kinds of data that can be used to train machine learning algorithms. People here are well aware of that, right? And my only point here is that all of these sources of data can be structured by injustice, as well as by many other factors that people here I know have spoken about, right? So things like site-specific provider behaviors can structure the data sets that you might use. Lots of things can structure the data sets. One of the things that can structure the data sets is injustices. So we have several different kinds of injustices, right? And often injustices related to health, or at least systematic patterns of difference in quality of health, proportion of people who have a disease, or the differences in the course of the disease, often referred to as health disparities. There's an enormous health disparities literature out there. It really got ramped up in the 1990s, when NIH began paying much more attention to the issue of race and gender differences in outcomes, disease course, and all kinds of things, and they began funding people to study this. So there is an enormous literature out there on health disparities. What I want to say is that, and so first of all, this pie chart, sometimes I call it the fictional pie chart, right? Because we don't have numbers, or we have a variety of different numbers that would divide the pieces of that pie in slightly different ways. And I'm not sure I would trust anybody's numbers on this. I think there's widespread agreement among experts that that bright blue piece of the pie there, which refers to, I don't know if you can read because the labels there are kind of small, social stratification. So various kinds of segregation in society, racism and sexism in society, things that happen outside of the healthcare system that systematically shape people's health. And I would say there is widespread agreement among people who study health disparities that social stratification is by far the largest contributor to health disparities, right? So when we see differences in rates of disease, in disease course, in disease outcomes, in treatment outcomes, a lot of experts would say that those differences are greatly influenced by social inequality. That's not the only thing, right? So I also have that gray section there, stuck at the door, has to do with access to healthcare. So that's a kind of social inequality too, but I broke it out as separate because it's sort of at the intersection of the healthcare system and the larger society. The orange piece of that pie chart, that refers to actually what we might call unequal treatment. That is events, things that occur within the healthcare system where people are systematically treated differently, even if their disease might present all the same way. And so again, lots of data on that subject. I'm just going to talk about one or two things. And you heard a little bit this morning as well, maybe. Well, I don't know, endometriosis maybe not quite an example because, well, it's an example of things that happen within the healthcare system. I'll just say that much. And then finally, that little yellow piece of the pie, that yellow piece of the pie refers to sort of biological differences. So differences in allele frequencies, maybe epigenetics, things that basically are more intrinsic that can influence the course of disease. I think most people who study health disparities think that a vanishingly small proportion of health disparities are actually caused by intrinsic differences between people. Again, it's the fictional pie chart, right? I don't think we really have the data to say exactly what proportion of health disparities are caused by intrinsic differences between people. But so we have these different sources of disparity. The question is, okay, if your machine learning algorithm finds or reflects some systematic difference between patients in a medical data set, which of these kinds of difference is it reflecting, and what should we do about it, right? Because even if there's a lot of social injustice up in that big blue piece of the pie chart that leads to health disparities, those are disparities that walk in the door of the healthcare system. They're real, right? That is the embodiment of racism, gender inequality, and things like that. That leads to real differences in people's health. If our algorithms can identify that and help the system respond appropriately, then the algorithms could actually maybe ameliorate some health disparity and increase the justice of the system. One of the concerns that people have here is that a lot of times it's difficult to identify those kinds of health disparities that walk in the door as being largely caused by social inequality. They often get represented in the medical literature as they must be intrinsic. And people who study health disparities and who study justice and social justice worry about representing differences as intrinsic because that has been part of the history of race and gender discrimination in the world for a long time. And it's often just wrong, right? But if those differences get represented to the world and to the medical community as being something that's just unchangeable about people, then we might respond the wrong way. And rather than trying to have targeted treatments or making sure that we do the appropriate preventive interventions or surveillance or education or whatever, we might represent certain groups of people as being just sort of intrinsically less robust than others. And historically, that has happened, which is why people worry about it now. And with machine learning, having it has an aura of authority, right? It has an aura of objectivity as this is just math. And so people see this as particularly having the potential to be very problematic because it could represent things that are social inequalities that could be changed as instead intrinsic unchanging properties of groups of people, right? So arrives at the door, how do we respond to that? How do we identify it? How do we respond appropriately so that we actually help people and don't perpetuate, ugly stereotypes about intrinsic differences? When a disparity happens because of things that occur in the medical system, really the appropriate response is to change the way the medical system treats people. But figuring out which kind of disparity it is might be quite difficult. And again, the sort of stuck at the door disparities that occur because of differential access to healthcare, machine learning could be used to identify systematic differential access and to try and do something about it. Or it could be used in ways that, and I would say most of this would not be by the doctors, but by payers or the system, right? To decide, we should send that group of people home earlier. They're not really at risk. Or, we really don't have to pay for a certain intervention for that group of people, which could be true, or which could actually be good medicine, let's put it that way. Or it could be medicine that just is reflecting back already existing inequalities of who has access. So I think, again, machine learning has a role to play with respect to all these different sources of health disparity and potential injustice. or existing injustice, right? Machine learning could make it worse or make it better. All right, so I want to talk a little bit about unequal access, but just a very, very little bit, because I think it's like actually pretty obvious, right? That unequal access also structures the data that we have. And sometimes in ways that you might not anticipate. For instance, different payers will pay for different lab tests for the exact same thing, right? So knowing who is in a particular health data set and who the payers were might tell you a lot about the nature of the lab tests that are reflected in that data set. So that would just be one example about how differences in access can structure data, and they might structure it in ways that aren't apparent and obvious to you. There are lots of other barriers to access. People who just don't get in the door at all, or who get in very infrequently, or who receive their health care paid for by various, by say Medicaid. Those people might not see the same provider as often. They might not have, so there's some data suggesting that they often don't have a primary care provider, right? This can affect the sufficiency of data that they have in a medical record. And that means that when we're doing our data cleaning and we're looking at sufficiency as a quality measure, we might be systematically dropping out poorer people because we don't have enough of their data. So I'm not sure exactly what to do about that, but we ought to at least know that that's a possibility, and perhaps we ought to be looking to see if that's occurring. All right, I'm just going to go right past that. So as I said, we have, sort of access issues. We have various kinds of biases that occur in society and affect people's health. So housing, education, employment segregation. Right now, we know, for instance, that housing and education segregation is actually more extreme at this particular moment than it was in the 1980s or the 1960s. So, and in particular, a greater proportion of children who are either Latinx or Black now go to schools that are either more than 50% or more than 90% students of color, right? So there are lots of studies on education segregation, and it has actually increased over the past decades, despite anything in the law. So these kinds of segregation affect what kinds of health information people get, how they relate to their healthcare provider. Housing and employment segregation systematically affect people's exposures to toxins and stressors and other things, right? So there are all kinds of ways that these larger social phenomenon can systematically pattern our health data. And those patterns can be local, but they might not be so obvious as local and contingent, right? They might just look natural and intrinsic, like this group of people is more prone to a certain disease, right? Because we might not actually have the data that show us, like, oh, they've been exposed in their, their residential environment to really high levels of lead that other people have not been exposed to. So they might just look like they're somehow intrinsically more susceptible to a medical problem. So what I want to say is understanding that, those kinds of problems walk in the door, and in those settings, somebody's self-identified race, their gender, or whatever, might indeed be relevant for predicting their health outcomes. Even if it weren't truly relevant for predicting their health outcomes, I don't think that we could get rid of that information because there's so much in a health record that is actually a proxy for things like race and gender, that even if we wanted to get rid of that information when we were training our algorithms, it's not clear that we really could get rid of that information. It might be relevant. The question really is how to use it in the right way. So yeah, I'll just stop with that. All right. So that's just a teeny tiny taste of how sort of larger social stratification might affect the data that you use to train your algorithms. Unequal treatment, right? So once people get into the healthcare system, there are other things that happen that can structure the data. I don't have time again to talk about this. There's a very famous National Academies report that came out, I think, in like 2002 called Unequal Treatment. Maybe it came out later than that. Anyway, it was updated in about 2016. And it makes for pretty disappointing reading in terms of a real survey of the literature on the ways in which people are systematically treated, undertreated, or inappropriately treated based on their race or gender. I'll just put it that way. So unequal treatment can happen for lots of reasons. And sometimes it's because of things that patients do, right? So this isn't only just to like cast blame and fault on the healthcare system or the practitioners, right? So patients come to the healthcare system with beliefs and behaviors about health, willingness to talk about health, and those things can differ based on race and gender and culture and so forth, right? But there is ample demonstration that there is both implicit and explicit bias, as in pernicious bias in the healthcare system. So, and then there is poor training of healthcare providers. So we heard a little bit about endometriosis this morning. I'm just going to give 2 examples, really, here of other kinds of, in one case, a gender difference. So it's actually well known and widely studied that heart disease of various sorts is underdiagnosed in women and undertreated. So this is a 2016 paper that was done by the American Heart Association, in which they surveyed all aspects of sort of heart disease and heart disease treatment in women, and they found all kinds of systematic problems. Both doctors and patients tend to think of heart disease as a male disease. So women are less likely to go to the doctor when they're having symptoms, or they don't get in as quickly. But when they do get in, doctors are slower to diagnose them. Doctors are less confident that they have accurately diagnosed them, and they much less frequently provide guideline-recommended care, right? And this is another example. So this actually looked particularly at premenopausal women, so younger women and men, and found, as you will see up there, all kinds of statistically significant differences in which women were undertreated as compared to men, even when women and men presented to the doctor with the same set of symptoms. There are also experimental studies in which you just take a medical record or a case, basically. Most of the details are about the symptoms, and they're gender neutral, and you pretty much just change the name and the gender, and you can see that doctors recommend less guideline-recommended care in the cases where the name was a female name, right? So we have all kinds of evidence that women are very undertreated for heart disease, even though, according to the CDC, heart disease is the #1 killer of women. So this is just one example. I think it's a very important example in which things that happen in the healthcare system, it's basically implicit bias, a sort of unconscious and sometimes conscious assumption that heart disease isn't really a woman's problem, that leads to poor treatment, and that's going to be reflected in essentially all the healthcare data that people are using when they train their algorithms. So how do we deal with this? Especially from the technical perspective, I don't have good answers to that question, but what I do want to do is tell you that you need to be thinking about this, that it's not just a technical problem, it's also an ethical problem, right? And so we as a community need to be developing some guidelines about how we deal with problems like this. All right, race also affects the way people are treated in the healthcare system. Again, enormous amounts of data on this. I'm just going to give you one example, which is that non-white people are undertreated for pain. And this was actually a study of the amount and kind of pain medication that was given to children after they had an operation to deal with their appendicitis. But there are many, many, many other studies showing that comparable kinds of procedures for white people and people of color lead to far more pain medication for white people. Now, mind you, this is often framed as people of color undertreated for pain. Perhaps there are times when white people are being overtreated for pain, right? So it's not always straightforward and easy to understand where the injustice even lies when you see a disparity. But we also do know that, for instance, doctors, so this goes to training, doctors have been trained in many cases. They were explicitly taught that black people experienced pain less than white people did, that black people were less sensitive to pain. This was in medical textbooks for a long time. It goes back to the era of slavery in this country. So I was just reading a medical historian the other day who argued that that view that was explicitly in textbooks until kind of the early to mid 20th century is still influencing the way doctors practice today. So again, just one of the myriad examples of how things that happen in the healthcare system can influence the data that your algorithms are going to be trained on. So I want to give this last example really quickly because I think this is an example of how things could go right and how algorithms could actually step in to help us do things better with respect to those problems and injustices that occur within the healthcare system. So this paper, which is an oldie but goodie, is from 2002. It was from a special issue of JAMA that looked at diabetes and diabetes complications. And every single other paper in this special issue found pretty significant disparities between their white patients and their Latinx patients and their black patients, where the Latinx and the black patients came out with much worse outcomes on many different kinds of complications from diabetes. This paper was written by people at Kaiser, and what Kaiser did was they saw those same differences, but rather than assume that there must be a genetic explanation for why people of color were having such bad outcomes, which is actually what some of the other papers said in their discussion section, Kaiser said, we are going to expect that all of our doctors will provide guideline-recommended care to all of our patients, and we're really going to train them to do that, and we're going to enforce that on them. We're basically going to make them explain if they didn't provide guideline-recommended care, why not? And what this paper shows was that almost all of the disparities disappeared when Kaiser did that. So despite the fact that all of these other healthcare institutions thought that we're seeing these disparities and, well, we think it must be due to genetic differences that basically make Black and Latinx people a little sicker or have worse outcomes, it turns out that if the healthcare system gets serious about making sure that people with similar disease presentations get similar care, you can make almost all those disparities go away. So if our algorithms can identify those kinds of situations and they are used in the right way, they could actually really help us to practice better and fairer and more just medicine. All right. So the last thing I want to say in terms of how data gets structured in ways that can affect justice is this. So some of the data you're going to use are going to come from research, and this is especially true in the precision medicine era, where we start thinking about experimental data and genomic data. So it turns out that a lot of our genomic data disproportionately come from people from whose ancestors were from a very few parts of the world, particularly Northern Europe. And so this paper was actually an update of a paper that was done in 2009. And then the work was basically repeated in 2016. So what they found in 2009 was something like 94% of all the GWAS data, the genome-wide association studies, were done in people of Northern European descent. By the time we got to 2016, the number was more like 80% of all the GWAS data in NIH's big database were about a little over 80% were people of Northern European descent. So things had improved, but less than 4% of the data came from people who were of Middle Eastern ancestry, of any kind of Latin American or Caribbean ancestry, of African or African American ancestry. So basically, the change between 2009 and 2016 happened because China and Japan really stepped up their genomic studies, and so there was a lot more data coming from people of East Asian ancestry and background, but there are still large groups of people for whom we have almost no genomic data, all right? So this is another way in which the data sets that you might use to train your algorithms are going to exclude certain groups of people altogether, may not be totally relevant for certain groups of people. All right. So this is just a kind of review of ways that data sets get structured, right? So because of social inequalities that affect people's health, because of inequalities and bias, pernicious bias within the healthcare system, and unequal treatment, because of unequal access to the healthcare system, and then because of genetic and other biological factors, and left out of this were maybe, sort of unequal treatment in the research context too, or unequal access to the research, or unequal willingness to participate in research. All right, this is my one sort of technical slide. I figure there are so many people here who can talk about this kind of thing better than I can, but data cleaning and other data preparation can exacerbate these kinds of problems that are already in the data sets. And I am sure I personally don't know all the ways that that could happen, but I do know that because so many times we drop out data which are viewed as less complete, we are almost certainly systematically dropping out people who are poorer, often people who are not white. There are probably other ways that data cleaning and data preparation exacerbate these problems. And what I have observed is that talking about or thinking critically about those aspects of machine learning, the sort of data preparation aspects, doesn't seem to be the really sexy part of machine learning, right? It's not the part that people want to spend a lot of time on. It's probably not the part that people get a lot of professional acclaim for doing. And yet, it may be a really important aspect of helping to understand where there are potential injustices and inequalities that could get incorporated into the sort of algorithmic products that we produce. All right, so my last thing that I'm going to talk about, what can we do to tilt the balance here more towards justice? And here I'm going to get a little preachy in a sense. I mean, I have some ideas about this. And so first of all, we should have already maybe come to the conclusion that I think that we have sort of a dichotomy. One is a set of situations where we need to have an appropriate medical response. There's an inequality, and the way we could decrease the inequality or injustice is by the algorithm identifying it appropriately and motivating an appropriate medical response. Another thing is just to avoid the disparity. So basically, avoiding the disparity needs to happen when the inequality happens because of something within the medical system that could be changed within the medical system. And then what we need to do is be able to identify it as the kind of inequality that we just could be able to avoid altogether. And so, of course, the hard problem is how do we know which type it is if we see it in our data? So first of all, this goes back to the unsexy aspects of really thinking about our data sets before we train our algorithms or while we're training our algorithms. I think we need to analyze them more and actually have metrics to understand the nature of structuring related to things like race and gender, right? And to understand how do those aspects of the data set change before and after cleaning. We also might think about how to use statistical approaches that explicitly take account of these kinds of structure. Again, I don't know if we could do that or do it well, but we at least ought to be thinking about whether we could do it. My biggest concern is that I think we need to spend a lot of time experimenting with our algorithms once we train them. And I am not by any means suggesting that this will be easy. And part of the reason it won't be easy is because I think it's difficult to get a hold of data sets that let us do the kinds of experiments that ultimately we ought to be doing in order to best understand our algorithms. But, so if you train the algorithm on a data set that comes from one healthcare system, ideally, we would like to see how it performs on data from somebody else's healthcare system. But getting our hands on those data might be difficult or even impossible in some cases. So I'm aware that we live in the less than ideal world, but I think we need to do the best we can and work hard at doing this. I also think that this is part of working with people who have the domain-specific knowledge, which seems to me as or more important in healthcare than in any other area in which we're applying machine learning, right? There are so many weird quirks about health data and how they actually get created and what they actually mean. People who are not accustomed to working with health data do not understand that different healthcare systems deploy their ICD-9 and 10 codes differently, right? For the same kind of healthcare visit. And they're all trying to game a system of getting more money by coding in various creative ways, right? If you do not understand those things about the data, I think you are more likely to generate an algorithm or set of algorithms that are going to exacerbate inequality or just be harmful because they actually come to mistaken conclusions or provide guidance and support that is confusing to healthcare professionals at the very least. So, working with people who have the domain knowledge and then actually experimenting with these algorithms, not just trying to do the validations, but actually trying to test them to see where their quirks and weirdnesses are and where we might get indications that there are kinds of inequalities built into them. Then the question is, what do we do about that? Right? What do we do about that? So one thing we can do about that is actually have better ways of explaining the limitations of our algorithms to the users. And one of the things I've been working on a lot right now is working with the FDA about their oversight of medical algorithms. And it turns out that, of course, labeling of medical devices might be one way one would, sort of explain the limitations. It should be legally one way. But labeling of medical devices is a kind of underdeveloped field, one might say. There is no centralized place to do it. People who are users don't go to the FDA's website to look for those labels. So I think there's a lot of work to be done to figure out how we explain to algorithm users what the limitations of the algorithm are, and the ways in which it should be used, and the situations in which it's not indicated. We also have, for instance, algorithms that assess the fairness of other algorithms. The ones I'm aware of are algorithms that have been developed in a context that might be a little more straightforward than healthcare data, but we also ought to be thinking about how to implement those. All right. And with that, I am going to end. I only have like a minute left on my time. So I want to thank you all for listening, and also thank Mark Craven, who was the PI of our Big Data to Knowledge Center at UW over a few years. And I think it was because of that center that I got involved with thinking about machine learning at all. So I want to thank Mark Craven and all the investigators of the center. Thank you.
Okay, so we're going to do the same drill as the morning session. For people who have questions, just line up at one of these two microphones. And can the spotlight presenters line up by that railing over there and get ready to come up and give your little talk? Okay.
Here we still might. I think so. I'm not sure. I can go over here.
Taking direct action to, should FDA be taking direct action to try to combat these sources of bias in data? Should they be requiring certain types of evidence for algorithms when they are approving them, or what should the agency be doing?
So this is a whole other talk, and I have a draft of a paper on FDA and regulating algorithms, and I have a draft of a paper on like justice and machine learning. So first of all, FDA most of the time will not approve algorithms, it clears them. So clearing is a much lower evidence barrier than approval. Nonetheless, FDA does set standards on how much and what kinds of evidence need to be presented to the agency before it authorizes a medical device algorithm to go out in the world. So two things to know. One is that not all algorithms will count as medical devices. So some potentially important algorithms that could be very consequential in medicine will go out into the world without any agency approval. Then it's all up to the researchers to be ethical people and to, use high quality science, but also I think as a community for us to develop standards about, responsible uses of machine learning in healthcare. And if we develop those standards, the FDA is likely to look to those standards also when it's thinking about how much and what kinds of evidence people need to present. And right now, it has to do that on basically a case-by-case basis.
Thank you for your talk. I think it's super important and just very, very interesting stuff. I was wondering what your thoughts were on differences in concepts like justice and concepts like fairness, and if you see any distinctions between those two, and if one of them might have some kind of notion of addressing potentially by overcorrecting this sort of thing, and maybe it could average out, and if not, what could some other differences between those two concepts be?
Wow, that's a super complicated question, and so mostly I'm going to take that offline since we're basically over time at this point. But I think fairness often focuses much more on distributive justice and on procedures for ensuring that what we distribute is fair. I think many theories of justice encompass the notion of fairness, but maybe also have some broader notion of justice as involving things like institutions interacting respectfully with people or treating people respectfully. So it's interesting, John Rawls, his theory, he talks about justice as fairness. But on the first page of his famous book on justice, A Theory of Justice, he has the sentence, justice is the first virtue of social institutions. And when I took my first class on justice theories, the professor talked for almost 2 hours on that one sentence and on how the change of thinking about justice as a personal virtue versus so how there had been a change in the philosophical thinking about justice to think of it as more of a feature or function of institutions and how like maybe the state interacts with people or major institutions interact with people. So I think, those are some, to me those are like primary differences that stand out. And I think, and it's partly why I tend to talk about justice in healthcare. I think fairness is certainly part of it. And, there are some theorists who equate fairness and justice. So in some ways it doesn't matter so much which word we use, but I do think that, healthcare is, we're talking about major institutions, we're talking about structures within our society, and so focusing on structural aspects to me is important, right? Because, algorithms don't just get used by doctors, they get used by doctors potentially within a set of institutions and organizations that shape how medicine is practiced and even determine when an algorithm is going to get implemented within that institution or not. So to me, one of the important things is thinking about this not only as like person to person, but institution to patient.
Thank you.
Sure. And there's one other thing that I would say in response to that, which is I think one of the hard questions here is this. So we have a lot of data that comes from white people. What if we create algorithms that actually improve medical practice for white people? Like, is that unjust? And there's a way in which maybe it's not. And if you think of health not as a positional good, then maybe it's not. But I happen to think that A, health is a positional good. B, justice also involves how much the system actually demonstrates concern for everybody's problem in some kind of equal way, right? And so, although I think it's a good thing to improve anybody's health care, at a certain point, you could actually be increasing the injustice of our system by continually creating algorithms that improve the health of white people and leave other people in society further and further behind, or algorithms that improve the health of men and leave women further and further behind. So I think this is not only a problem for particular algorithm writers, it's a problem for the whole system to think about, is how are we going to be getting access to the data that allows us to write algorithms or develop and train algorithms that can help everybody and pay attention to everybody's problems. Maybe one more question, maybe? All right.
Actually, can we take that offline?
Yeah, absolutely. All right. Talk to you later.